how can we use the digital transformation and emerging tech for better diagnostics and prevention of the patients? Ma'am.
Thank you. It's a pleasure to be here with all of you. So I'll just add a little bit of context. Thank you for the introduction. So my name is Tasleem. My background clinically is I'm an emergency medicine physician. And in Toronto, where I practice, in Toronto, Canada, I should give the country, it matters, I've been working in the space of digital health for many, many years. And most recently, I was their Chief Medical Innovation Officer. We moved to Chief Medical Innovation Officer, not Information Officer, because of our maturity when it came to our digital implementation and our transformation. And that's part of the journey. Because we leveraged all of our data, we could now start moving to really creative ways to identify opportunities and excellence, both operationally and clinically. And the question I think that you posed was, why do you need the data, right? And talk about the importance of the data. I once heard somebody talk about data invisibility, and that term really resonated with me. If your data is not captured, especially in today's world, it's almost like you don't exist, because that piece of information is not contributing to all of the decision-making that is happening now. And that's why I asked that question to our previous speaker about the data that we're looking at. We need to make sure that not just one part of the world is represented in the data that we're looking at. But to go back down to a bit more of a micro level, how we use data in our hospital, we can't live without it now. We are so digital that when we have a problem like a downtime, everything stops, because stops meaning our physicians are angry, our nurses are angry, the pharmacists. It's not a way in which we are anymore used to working. And that is because our standard for high quality, safety, reliability is now set. So what we have and how we leverage our data is that we have real-time awareness of what is happening in our organization at all times. And that allows us to then use our data to make decisions about the system. It allows us to make decisions right down to the patient. So we're ensuring that we're moving from a place not just of leveraging the data for the system and for groups of patients, but right down to precision for the patient. And if I can give you one example before I pass on the mic, and this is an example not from my own hospital, because I also want to speak about what others are doing in this space. Unity Health is also a large academic hospital in Toronto, and they implemented something called ChartWatch, where patients that are either medical or surgical patients are monitored continuously on certain parameters. And what they're doing is looking at the likelihood of ICU admission or mortality every hour for these patients. And if the likelihood, of course, is above threshold, you implement certain interventions to prevent that outcome. They have found, since they launched in 2020, a 20% decrease in mortality. A 20% decrease in mortality, because they are using their data to now act upstream and prevent bad things from happening. And I think that is a powerful example of why we need patient data.
Perfect. Dr.
Yes, thank you, Dr. Tasleem, and thank you, Syed, and greetings to all the dignitaries and guests. So my name is Nadeem Ahmed. I'm the Chief Medical Information Officer for the Aga Khan University in Karachi, Pakistan. I should mention the country, right? But we have a major project underway to go digital with all of our data with the electronic health record. We did it recently in Nairobi, Kenya, at our hospital there with major success, full clinical adoption. And when you ask the question, how can data improve patient care? I ask the question, how about better patient data? Because as a clinical provider, I understand the concept of having multiple sources of information, and those sources of information a lot of times don't align. So a real simple example is a patient comes to the emergency department and the admitting nurse or the triage nurse asks, what medications do you take at home? They give the list. And that nurse writes it somewhere. Now this is a non-electronic environment. Then the admitting emergency resident comes in, asks the same question. He remembered one additional medication that he didn't tell the triage nurse, so now that gets written somewhere in the resident's note. Then the consultant comes in. Then it's determined that the patient should be admitted. Then the admitting nurse, admitting physician. So you can imagine the frustration that By the time myself as a hospital medicine physician would see to admit the patient, there might be 4 or 5 different, and then of course you have pharmacy techs, 4 or 5 different medication lists that the patient claims to take at home, but none of them match. And so that frustration manifests in many ways. Number one, the provider is frustrated because they have data they cannot trust. So better data means you have to be able to trust it, that this is valid, and I can act on this data, and it's not going to lead me to make an error in judgment when I say stop this medication or start this medication. I can't tell you to stop something if I don't know you take it. So for me, better patient data is really the crux of everything else, because you can have the best algorithms in the world. And I think, Dr. Taslim, the question you asked, not to harp on the previous, which was a fabulous presentation, by the way, and really exciting work that they're doing, but if your data is coming from a certain region, then your entire interpretation of how things are done, as you were saying, is based on that region. And it's very difficult to say it applies to other regions. But take it down to the more microcosm level of your patient. If you have various places where data is being stored about that same one patient, which one do you apply? And so for Aga Khan University, our biggest goal is to consolidate the amount of effort and to make things more efficient in the capturing of data. So when the data is captured, it's valid, it's usable, and then we can actually study it and do much bigger and better things so that we can do predictive analytics like you described. So I am honored and blessed to be part of this amazing organization so that we can lead, hopefully, the LMIC in pursuing better data for better patient outcomes. Thank you.
Good points. And Asif, please.
Assalamu alaikum and a very good morning to all. My name is Abdul Hasib. I'm Managing Director for TMC. We're a digital transformation company. We do these IT projects to gather data around healthcare, including other industries as well. When it comes to structured and established institutions like Aga Khan, obviously there is a will that my fellow speaker just explained as well. And an understanding of how to gather data, but still, when it comes to Pakistan and the projects that we have done locally around data, so on the maturity curve of data, we are still at step 0. So that is really gathering data from the field and making use of that data for some of the very basic use cases. So I'll share a few examples just to highlight the fact that the type of projects which are undergoing locally in Pakistan and where we are. So take an example of polio campaigns. It has been a hot topic for many years now. So now all of these vaccine agents, they have this mobile applications where we are able to gather this data that what routes have been covered and what are the vacant points where they have not covered from a data standpoint. And data is effectively used to identify and target the unvaccinated parts from a geolocation perspective. Take example of dengue, for example. So in dengue, there are applications which are currently being used to have spatial temporal based algorithms are being used right now to identify that when and where it is going to hit next. Similarly, we have seen in COVID as well that in COVID, based on reports from media, etc., the central control unit, they identified that where it is picking up, and based on that, they prepared responses for that as well. So these are some of the use cases that we in Pakistan right now have effectively deployed to gather data, to be able to use data, and to react to certain diseases and the upcoming diseases, and to be able to react and respond to the changes. So I think from our perspective, the importance of data is definitely there. On the maturity curve, we are on step number 0. We need to make sure that as institutions and as a country, how do we gather more data and use it more effectively in several other use cases which are right there in front of us. So I think that is where we are in terms of the data readiness.
Bismillah ar-Rahman ar-Rahim. First of all, thank you very much. I have a disclosure. Unlike the two gentlemen and the lady there, I don't belong to the IT side at all. Um, so there's not much of an expertise coming in that way. But we are the end users, and we need to understand where we are today. Hospital systems, obviously, in the developed world, this is not something new in 2023. And I'm sure the systems have been evolving and becoming better and better at getting the data. Also, the reliability and validation of data is much better if you're coming from a country like Canada or US, or you are coming from an institute like AKU. But situation changes when you're talking about the health system, okay? We are talking about a society which is still, in parts, not accepting polio drops. The validation we just talked about, and when we look at in depth of what's happening in the polio programs, we're not 100% sure when you're given a card, you're actually given polio drops. Okay, and that's where you have an issue, because you're relying on the person who's filling in the data. So for the health system, when we took over, and you would be surprised that the entire almost health system does not have a central, it's not digitized. And they made an effort in 2019, and then it stopped in 2021 for some reason. And we have actually restarted that. At the moment, it's not just about disease. I mean, we know that there should be, I don't think anybody would have any doubts about the usefulness, both in terms of how you would handle the disease burden, because you don't even know what the disease burden is. We are actually basing that on very small surveys in a country that's 200 million plus population. Most of them come from elite organizations or university hospitals. The ones that we have which represent the society are very small, When we started this digitization thing and we started talking about it, we were looking at multiple issues, and I think that's important for the government sector. For an institute that's run privately, I'm sure the costs can be covered and can be actually put into the cost of treatment overall, and that's probably what's done. Our issue is obviously cost, number one. Within the department, we need to have expertise, create jobs. So while I took this challenge, I was told that we can't appoint anybody because the Election Commission has told us that we can't. So we have to utilize what we have. And we'd have to use someone like the gentleman sitting next to me. The second issue we have in general is the cost. It's the cost of implementing, the cost of actually continuing, which is the most important thing. You set up a system and it doesn't work, you wasted money, and this is what happened. A lot of money was put in, a few years ago. And despite of a lot of hard work and software, etc., it didn't make it to the thing, so, it didn't become a reality. Now, the other problem that you face in the general system is acceptability. When you join Aga Khan University Hospital or you're in a Canadian hospital, you get in, everything is there. And I see Zafar there, and sure, in Indus as well. You go in and you know that they're sitting in front of a computer. Now, for the last 20 years, you've never seen a computer. And now I come and tell you, look, you need to put everything there. The acceptability is not very good. So we need to actually encourage. How do we encourage? And that's the problem in the government sector. And I'm obviously talking about the government sector and the realities. Like most of us, it was easy for me to criticize, but now I'm sitting and looking at some of the problems. And the problems are very real and sometimes very difficult, and I really don't have an answer for that. The other problem that we face is we did a hepatitis elimination project in a place called Kambar Shadat Kot, which is in the north of Sindh. And we picked up 20 UCs and we said, we are going to put in smart apps, etc., and everybody is going to be monitored. And we had 20 clinics, and we found out 7 of them did not have Wi-Fi. So we would not get real-time data from them. They had to save and then go into a place where there was Wi-Fi, there were Wi-Fi signals. Most of them did not have computers, so we had to actually put in computers or give them some kind of system. So these are the real issues. I don't think anybody would doubt that that is the way forward. We don't even know what the real disease burden is. We know that diabetes is very common in our country, but actual data would come once we get actually, digitized to the lowest level. The other issue is, as I said, my big problem is the data that is presented to me, I'm really not sure whether I can rely on it. Whatever data is given, I mean, I just went to Interior Sindh and I asked about deliveries. So there was one hospital which thought that I would be impressed by cesarean sections, and the percentage of cesarean sections was phenomenally high. And I said, why is this high? He said, we are doing a very good work. I said, well, you're not. Now, why are you? So because we have people who come and request us to have cesareans. I said, that is not an indication. And the other hospital I went to had very low cesarean section, and they were really kind of shy in sharing that with me and saying, sir, we only do this percentage of cesarean. And I said, that's fantastic. And they looked at me and said, they thought that, so these are the real issues that we face. And the data that was shown to me, the percentage of infection, the mortality is totally different to what we know. And now the same people are going to put in, give us the feedback. And this to me is the biggest problem. How do I rely, I'm sorry, on a population that thinks lying is not wrong? We are in a society which accepts lying as a normal phenomenon now. In fact, if you don't lie, there's something abnormal about you. Okay? So from the minuscule thing of saying, well, tell them I'm not at home or tell them I'm busy in a meeting, to actually serious lies. And this is, no matter what you put in, the end person who is actually going to file in the information, if that isn't reliable, no matter what system you put in, I'm not sure it's going to help us. And that's where we are struggling in the government sector. If you guys have a solution for that, I'd be very happy. Thank you.
Thank you so much for a candid point of view. And Dr. Taslim, you have a vast experience for based on your experience, but I will just take one use case of HRH. You have made a natural transition from informatics to medical innovation and led many innovative projects at Hub River Hospital, like remote patient monitoring, enhanced communication, virtual care. So please elaborate our audience in what ways HRS was able to achieve one of the best fully digital hospital of Canada, and what challenges you have faced during that journey, please.
If I can, I'll answer your question, but I wanted to comment on something that you said, if I may. And there's a keynote in the afternoon, and I'll talk a lot about our journey and our digital transformation at Humber, so I'll cover a lot of that there. But I'm so glad that you talked about the realities, because it is so difficult, and it's easy for somebody like me to sort of fly in and show you a very glamorous presentation and say, do it like we did. And that's just not a reality. But there's two things that you talked about, and something sort of popped in my head. And we talked about pace of change this morning. And we talk about Starlink and the ability to have increased connectivity in areas that historically have not had any access to Wi-Fi internet connectivity. And I think, at least I'm hopeful, that some of those challenges now are, in terms of their solutions, are not as far away as they felt 5 years ago. And when you talk about the lying, patients in North America lie too. But we need to understand why, the why. And often the lie comes from a lack of trust, or because I'm incentivized to get something that you're not actually giving me. And so if I sort of present myself a different way, I'll get what I'm looking for in this exchange. And I think about education for our patients, right? Like when you talk about polio drops. And I wonder, one of the beauties of technology is that you can scale and costs over time decrease. When you're using very human systems, that's often not the case. So if you think about the avatar that you saw this morning, that Khan presented, and I've done that before, like I needed to produce headshots and I didn't have time to go to a photographer and spend money, and I literally took my phone in my pajamas and took a selfie, fed it into an engine for $15 American, which is cheap in the US, and got back 20 professional headshots of me in a suit with my hair done. Like these things are so easy to do now, right? And I think about that avatar speaking in a language that is not English, that is local, that is wearing clothing that is local, and how we can use those technologies by even taking something and saying, okay, you don't have the phone here, but let me show you a video where a physician is going to teach you something. Before, you needed to get that physician to sit down, to do the lecture. That is going to become so much easier to scale, because even sharing education will just, again, become easier. And so I think over time, we're going to start leveraging different technologies to move people, to influence people differently than we have before. And trust is a big thing. We talk about digital sensitivity and digital equity in Toronto as well, because there are people that don't have the same access. And so when you're talking about remote care monitoring, not everybody has an Apple Watch. Not everybody is going to share their biometrics with you. They can't, right? So then we talk about surrogates, like when we want to find out if a patient is tachypnic or if there's increased work of breathing in, say, a pediatric patient that you've discharged home from hospital. There are tools that are emerging where you can sort of just take your camera and videotape your child for a minute, and that will feed back to the mother or the father. Your child is showing signs of increased work of breathing. You need to bring your child into the emergency department. And so it's becoming simpler and more accessible. And I know that's not an answer to your question, because there is a gap, and I certainly don't know and don't have the answers of how to solve that gap, and I'm sure no single person in this room does, but we are not single people, we are a team of people, and I'm hopeful that we can get closer to the solution.
Great points. And of course, we should learn from that objective. And of course, our Khan's system and EHRS implementation is also a game changer for the industry. So Dr. Nadeem, we already discussed about multiple emerging technologies implementation, example of HRS and all. But the implementation of these type of emerging technologies, we know AI, bias and all. So it also faced several challenges for you, for every implementation. And we know that, of course, in addition to the cybersecurity survey, one recent result that the health sector is the biggest victim of the data breaches after financial sector in 2022. So, and I think it would continue in 2023 as well. So please advise about the data privacy, data protection risk of your implementation cycle you have catered, and how can you measure your commitment to the protection of user or patient's personal information and all. Because user is the weakest link in all technological chain, we know. So please.
Thank you so much for the question. And I also very much appreciate your insight and outlook. So I think data protection and patient privacy, or patient data protection, however you would like to phrase it, that whole realm of governance, and that is the key, is you need to have governance established. So step number one. So I can give you a small example in whether it's in the United States, where I've implemented EHRs for many years and for multiple hospital systems. The number one question is, what's your data governance? What are the access rights to the individuals? What can they and can they not see in the system? That makes a huge difference, because if you give access to any random person to anyone's chart, then like you said, the human element is the data is now a free-for-all. Anyone can see it, anyone can review it. So you have to have a governance policy. And a lot of times you might ask, well, what is that governance policy based on? A lot of times that governance policy at your local institution is based on the national requirements or the state requirements that the data must. So for example, at AKUH Nairobi, we follow the Global Data Protection Act of Kenya. Kenya has its own Data Protection Act that they passed in 2019. So we had to follow that very closely to say, for example, that the data of those patients cannot be stored outside of the territory of the country of Kenya. We have to respect that law. That is that country's law. So that put a little bit of a burden on Aga Khan University because that implies we can't just put our data in the cloud. So all this talk about cloud really was hampered by a law that was trying to protect their nation's data of their patients from being sabotaged and taken advantage of by outside organizations, right? This is our data, we should own it, which is a fair statement to make. So global data protection laws in the United States, it's called HIPAA, Healthcare Insurance Portability Act, which talks about patient privacy and data protection, really start off where you can get some guidance on how should we establish our own data governance. And then your data access, and then how the data is stored, who can and cannot see that data, follows those laws. So I know in Pakistan recently, there was a proposal on patient data protection laws.
Yeah.
I'm not sure of the status if it's been
It is in a
passed.
draft stage
It's in
right
draft,
now.
yes.
Yeah.
So this is exciting. So from a government sector, what does the private industry need? We'd like some guidance. Let us blossom within the guidance of the government requirements. But if the government doesn't have requirements, then we follow GDPR, which is European-based. And that might not really apply to the local context of Pakistan. And on a similar note, and I'm so happy you're here, I'd like to add in a small request. In Kenya, and as they have done in the United States and many other European countries, they have incentivized, whether it's by cash or other means, private organizations or private hospitals to go electronic. So in the United States, a few years back, they told the hospitals, all of you, which at that time, most of them were paper-based systems, you have to have an electronic software. We'll give you 10 years. And during this time frame, if you do it in a stepwise fashion, we'll give you certain incentives. If you prove to us, based on certain metrics, that you have gone electronic. So rather than funding that private hospital, which that was too cost prohibitive, the government said, we'll just give you some incentive. So now everybody was on a rush to go electronic. And they were now budgeting themselves to say, for the next 5-year budget, we have to put in some money to become electronic. Because to Dr. Taslim's point, if we don't, we will become invisible because everybody else will be in that phase. Kenya just passed that recently. So if Pakistan can do the same thing, that will give us the motivation as private hospitals and certainly other organizations to really push in that direction if we have a strategic vision.
Great. And if we want to implement this in Pakistan, this would be a key takeaway for Sarsat as well. And people will need TMC type of organizations to implement it. So, Hasib, the root of the digital success is, we discussed that customer data, patient in our case. So majority of the organization today have a huge, even not in Pakistan, because we have worked for multiple global organizations, and they still have the dispersed data in countless siloed based system, and they have no clear way to pull them together. And few have petabytes of data in a data warehouses, but they are only using it for reporting. And recent survey, according to PwC, only 22% of the health sector companies, even in UK, responded that they know how to extract exact meaningful data from the overall data warehouse and all. So, Hasib, because you are one of the largest digital transformation implementer in Pakistan, so how can you use the emerging tech and big data and AI to influence the healthcare sector delivery, and of course in cooperation with your improvement like global transformation initiatives and all?
Sure. I think AI, big data, these are all very heavy terminologies. So as I explained earlier as well, we are really at step 0 on our digital journey as a country. So we have very basic things to do on data and on collection of data and on usage of data, so on and so forth. So I'll share a case study. We did a project in 2018 for PITB, which was really working for the health ministry in Punjab at that particular point in time. So the project was that they wanted to automate medicine disbursements in Punjab in a better way. So we developed a system whereby the framework agreements with pharma companies and then the actual requisitioning of those medicines to specific hospitals were automated. So whoever needed the medicine, they were to put a requisition using that system, and then they were supplied those medicines, and then it was tracked that which hospital had how many medicines. There was a parallel initiative as well whereby they put in a system in all hospitals. So hospitals have different levels as well within a province in Pakistan. So the larger hospitals are district level hospitals, DHQs essentially, which are large hospitals. So usually patients from remote areas are taken to those hospitals as well for critical cases. So that was no fancy system. It was not an EMR per se. It was a very basic system which just recorded the admission slips of the patients. So whenever a patient used to come in, they used to enter what the patient came in for and what was the disease and what was the treatment for. As simple as that. So just based on that one form, I'll call it a simple form, that one form, the information that it was collecting was so useful that in future it was predicted that it was sort of known and reported that which provinces get what diseases at what time based on the patient inflow. And that led them to use the other system, which was medicine disbursement, simple replenishment of medicines to the right hospital at the right time. So at the end of the day, if a hospital does not have the medicines required for a particular patient, we have a healthcare system which is beyond public healthcare as well. But it is a big achievement if a public sector hospital is able to provide timely medicines for a surge in disease at the right time for the right type of disease. So that was a big achievement as well. So building upon your question of how we can use different systems to collaborate, this was just I just wanted to illustrate by this example that a very simple system of collecting data at a very basic level resulted in a huge impact of medicine availability in the right hospital at the right time, and they're still using it across the board as well. So what we need is, I think, very basic initiatives at public sector levels to collect these data sets and to be able to use them effectively and thereon. Given our challenges around data literacy, IT literacy, to be able to use computers, if such basic things can be done, adoption will be easier. We'll be able to get on these systems quite easily as well. And the outcomes and the benefits that we'll be able to get out of these systems can be huge from that perspective. So in conclusion, I think the very basic data collection to, I'll call it essentials. So from a data perspective, we need to focus on the essentials. And if we do those rights, we can move on to step 2, 3, 4 and thereon.
Great, sir. So last question to sir. Saad Saab, mainly based on your experience overall and now for the upcoming, you can say full-time health minister, what are your 3 key recommendations to him despite all the limitations and constraints that he should opt 3 key factors to improve the health sector in tech-oriented health tech environment?
Okay, thank you so much. I gave you the negatives, okay, because that's where we are. I mean, he's a very fair man. He said 0, I think we are in negative with the society overall. Let's not pick up the spots that are doing very well. We have some, this institute is like any international institute anywhere in the world, so, but this is not Pakistan, the real Pakistan. So when I was given this task, and as I tell my friend that I was given this task, I'm sure for my sins, we looked at things. Now, you're looking at one aspect of automation, which is health care, or disease data, utilization of medicines, etc. Our problem, and Punjab is much ahead of, I think, every province. They've got everything automated, and that's what actually triggered this. Our problem is that at the moment in the health department, SIN, the postings, the promotions are all done on an ad hoc basis and on a piece of paper. So we don't even have that. The procurement of medicine and what the stores in the hospital are again in the same state. So with the limited time that we had, we decided that we were going to pick up two things, and one of them was to digitize. Because for me, the biggest problem here is, can you imagine 20% of doctors in are not coming and still getting salaries? Would that happen? Would that happen in a hospital like Indus? No. Would it happen in your company or a private? Or no. This is what's real. This is what is happening. People don't turn up, and they've got their own ways of getting about it. So we need digitization not just to get the data for the kind of health issues we have, but we also need to them equally importantly for ensuring that what we are saying is available to the people is actually available, right? Once we have that sorted, and the transfer system actually, and the promotion system brings the whole, enthusiasm, the tempo goes down in the entire sector because everything is done on an ad hoc basis for reasons that we all know, okay? Everything has, has blessings of Qaid-e-Azam. So we needed to stop that. And I thought one of the ways that would make it a little difficult is to bring this. What you just said is very important. What we are doing is we are going in for all the medications, central procurement, hospital, availability, utilization of medicines. So we are actually tackling each one of them from primary care to tertiary care, and making a central dashboard which would then give the person who takes over and or whoever is looking after to ask the guy, we can actually track them through their mobile where they are. Now, knowing in Pakistan, I know they would give the mobile to someone else, but then they have to be very careful because they don't know when a phone call will come and say, well, switch on your video, let me see where you are. So these are the kind of things that are rather real in our part of the world. Last thing you just mentioned, I've become a little cynical after these 3 months. Why do we lie? It's just part of us. It's I think what we enjoy as a nation. How can I deceive you? That's what makes me good. Not how do I deliver. And just to share this, because I'm sure most of your doctors or medical. When I joined the health department, in the first few weeks, I had no idea who I could trust or talk to. Because everybody would come and tell me, this guy, be careful, he's very corrupt. He came to me and he would say, this guy is more corrupt. And they would come, oh, you think that lady is very nice? Forget it, she's the worst. Not you. So, it's been very challenging, but I can assure you that one of the things that we will do before we leave on 8th of February is actually we'll have this thing implemented in the government of Sindh, inshallah. The second thing is obviously related to health insurance, which again will bring automation and also will bring further checks on our hospitals. Perfect. So these are the things that we are. If I'm not going to get another chance, because looking at the time, then I've decided that in every place that I go, my last words would be related to a prayer for people in Gaza. The atrocities, the data that is coming out from one side and doubted by the other is actually telling you when you don't want to rely, you will not, regardless of how true it is. So my request to all of us is just to keep them in your prayers. That's the least we can do. And look at the double standards of the so-called liberal societies and so-called advanced societies of the world, we are not that bad looking at what's happening in Gaza, looking at what countries that are so-called, developed doing. So with that, thank you very much.
Thank you so much, sir. Thank you so much. Yes.